Hi everyone, my name is Emma Bob. I am the program director for the ultrasound program or the Diagnostic Medical Sonography program at Brown University Health School of Medical Imaging. Really excited to be able to get to speak on behalf of my profession that I have such a passion for. Maybe some of you who are listening to this are really interested in getting involved in ultrasound, and maybe some of you are not, and hopefully I can persuade you to maybe reconsider a profession in this field or in this specific modality. I'm pretty biased. I tend to speak very highly of ultrasound, and hopefully I can inspire some of you or maybe answer some questions that you've had or give you some information that you didn't really know was out there in relationship to this profession. We're going to be talking a little bit today about some credentials in being a multimodality technologist, which I personally am. You can see underneath my name here on this slide all of my credentials. We'll talk about what all of those mean and really the importance of being well-rounded in any medical imaging profession. But before we get into that, I do want to talk a little bit about some common misconceptions and really kind of just some general public thoughts about ultrasound, what we do, what our role is, and really how that differs from the reality of this profession. Most people tend to think that ultrasound is really just looking at babies and being able to notify parents of the baby's gender or get really cute pictures of the baby's face and do like these really cool 3D images for our patients. And while that's a very small portion of our profession, it's really, the importance behind that is very different than what the general public tends to think, and that initial first thought about what ultrasound is. A lot of people, social media, the general public, they really think that our job is super fun and easy because we're just looking at those cute babies. They think that we're kind of just playing a big video game and we're pushing buttons and that it's relaxing. We tend to operate in dark rooms that are quiet, and it's this calming environment, and it's really not stressful, and that we really don't know what we're looking at, and that there's low accountability in this profession, right? We're really just taking pictures, and that could not be further from the truth. So the reality behind this profession is that yes, there is a small portion where we do look at babies, and we'll talk about that in detail and what that involves today, but the majority of this profession is pathology and cancer diagnosis. We are the eyes of the team. We are the eyes of the radiologist, which is the person who's going to be reading and interpreting our exams. We're also the eyes for the patient's physician and the patient's care team. Most of the time, we are the first person to know that a patient has cancer, and we can't say anything, and we can't let that be known in that moment because we're not the provider. We are not the physician, but we know these things, we see these things. So there's a lot of weight that comes with that. We're also doing a lot of really interesting up and coming advancements in the technology of ultrasound. So we're doing more sports injuries, which is really neat and something that has been really new to the field. We're doing what's called musculoskeletal ultrasound, which we'll talk a little bit about as well. That's our newest type of application that we can use ultrasound for diagnosis. It's getting patients out of MRs. MRIs can be really long, they can be really uncomfortable, and they can be really expensive per patient. So we're tending to use ultrasound as a first step in more indications and for more reasons. Unlike all of the other imaging modalities, we have a very unique relationship with our physicians. So either with the patient's physician, with an ER physician, or with a radiologist. They have to trust us because we are their eyes, right? So we have this really unique balance in the care team where you might not see that as much in the radiography pathways or MRI pathways. So it's very unique, and there's a lot of responsibility that comes with it. We have to have really high quality patient care. We have to have really precise imaging techniques. We need to be creative with our approach to how we're scanning things. And, we can't really rely on our equipment to do the job for us. It really all is within how we operate that system and that equipment for the patient. So it's a very unique position and unique profession within the medical imaging sect of healthcare. There are a lot of opportunities for career advancement. We've seen a lot of students go off and get into sales or applications or take lead technologist positions, move up into management. So there's always another opportunity for you in your career in the future to really develop yourself. We do tend to make good money, and we'll talk about that a little bit further on as well. So, with the high responsibility, with the, very independent demand on your skill, we do make money to compensate for that. And at the end of the day, you want to do this because you want to help patients. You want to help people. You want to care for people. You want to find an answer for them. Even if it's not a good answer, you still want to find an answer for them. So it is very, very morally rewarding at the end of the day. I'll try to intertwine some stories here as we go through some of our slides about my clinical experience and my experiences as a tech and how to kind of relate to your patients. If we have some time, I'll try to sprinkle those in, but I want to get to really the meat and potatoes of what this profession is. So now that we have all of these misconceptions out of the way, we're going to get into some of the hard stuff and really talk about what ultrasound is on the day-to-day. So a couple things here, pretty straightforward information. This is something that you could find from a quick Google search. It's not really anything that's groundbreaking here, but ultrasound, the pros of this imaging option are that there is no radiation. So not only does the patient not need to worry, but the staff don't need to worry as well. So we don't have to take extra safety precautions due to radiation. It is very, very fast, meaning we can have an instant diagnosis. We're not waiting for a machine to process. We're not waiting for a system to develop or things of that nature. We can look at something live time or real-time imaging and get our diagnosis. It's also portable, meaning that we can take an ultrasound machine anywhere. You can't take an MRI or a CAT scan machine anywhere, right? So we can wheel the ultrasound machine right to where the patient is, whether they're in the ER, the OR, if they're too unstable to come down from their hospital room. We see a lot of travel ultrasound companies where they take a mobile machine and they go out to nursing homes or they go to care centers and they provide care where the patient is located. And that is super, super convenient. We are also very accurate. We have a 2 millimeter margin of error, meaning we can see anything 99.9% accuracy if it is larger than 2 millimeters. That's not to say that we can't see things that are smaller than 2 millimeters inside the body. It just means that that accuracy rate goes down a little bit. So we really are a precise imaging modality. And we're affordable. So an exam can cost anywhere from $150 to maybe $500. We're not looking in that ballpark of $5,000 for a scan, like some of our other modalities can reach up to. Now, the limitations of using ultrasound is that we cannot use it to evaluate anything going on with the bones, the bowel, or deep structures. The reason being is that we're using sound waves, right? We're not using radiation, we're using sound waves. And sound waves are a little bit gentler than radiation waves are. So we're not able to see through very, very dense structures like bone. We're also not able to see very far into the body. So patient body habitus does come into play here with some of our deeper structures. The sound wave just isn't able to travel that far into the body if our patient has a very large body habitus. And bowel, the sound waves tend to not behave well with air, and our bowel is filled with a lot of air. So those are some of our limitations in terms of what ultrasound can do. The other thing that you have to be aware of as an ultrasound professional is that you are manipulating the equipment for every single exam. You'll know that in X-ray or MR or CT or any other imaging modality, you're positioning the patient, you're setting up your equipment, and then you're allowing that equipment to do its job. In ultrasound, we are physically touching that patient the entire time to get all of those images. So there's a lot more wear and tear on our bodies because of that. So we see really high amounts of occupational injuries with ultrasound, but there are a lot of things that an individual can do to prevent that. So in the program, we do spend a lot of emphasis on ergonomics, which is how to do a job efficiently and safely for your body health. And we put a lot of emphasis on knowing your physical limitations and getting creative with obtaining your pictures and not hurting your body at the same time. So just some basic pros and cons. We also have some, kind of gray area between, depending on how you see this, you might be thinking that it's more of a pro versus more of a con. So it's a user-dependent profession, right? There's a lot of responsibility that comes with that. So if you're a nervous individual and you don't want to have a lot of responsibility in your job because it can cause you anxiety or it can cause you stress, you might want to reconsider getting into this profession. You also have to have a high emotional intelligence. A lot of our patients are coming to us because something potentially bad is happening, or something sad, or they're nervous, or they've been through a lot and they're looking for answers. And you can't take on that patient's emotion. You have to still maintain your professional state while knowing how to be empathetic to those patients. For example, a lot of women can come in for what is called a fetal viability, which is looking to make sure that their early pregnancy is stable and progressing appropriately. And unfortunately, during the first trimester of a pregnancy, we do see a lot of spontaneous miscarriages for reasons that we just don't know. And a woman can see on the screen if there is a heartbeat or not. So they're in tune to that. Even though we can't say what's going on, we can't show them what's going on the screen, they can still see it. And they're still knowledgeable people. So they, can get a little bit sad, they can get overwhelmed, they can get emotional during those situations, and you have to be able to handle that. So it's a very it's a tough balance for a lot of people, especially when they're first starting out. You want to maintain your high level of professionalism, but you're also a human being trying to relate to another human being about something that's really unfortunate or emotional. So it's finding that balance, and that takes time, and that takes just experience. You also have to be able to think critically. How am I going to get a picture if I cannot do A, B, and C? How are we going to do this exam if the patient has this going on? How am I going to work around all of this other ICU equipment that is in the patient's room, but I need to make sure that, they're okay? How am I going to do all of these things? You have to be able to think through that. Direct patient care. If you do not want to be working with a patient all day long, if you are uncomfortable touching a patient all day long, this is probably not the profession for you. If you're looking for something that has a lot of direct patient care where you really feel like you're making a difference in that person's life, this is for you. Again, going back to that high responsibility, we've said this a few times, so it's just a lot. And some people can really want that, and other people can be a little bit afraid of that. And you also have to have a depth of knowledge. We have to be intelligent people to do this profession. This doesn't mean that you have to be a straight A student or a 4.0 GPA. That's not necessarily what we're trying to get across here, but you have to put an emphasis and a priority on your academics when you are in this program and you are learning this profession. This is not something that can be crammed. This is not something that can just come naturally to you. Maybe if you've just always been naturally studious and you kind of come into this program thinking that, it's just going to be a cakewalk, I can tell you right now that that is not going to be the case. Most students, it does not come naturally. Most students have to put in at least twice the amount of effort that they're used to. And that can be a little bit off-putting, but that is why it makes this profession so rewarding at the end of it. Program completion is some of the happiest moments that my students have had in their lives because they know how hard they've worked for this and they know what their future is going to look like. So just kind of give a little perspective on all things to consider when you are looking at a program like this. So what is ultrasound? Very, very briefly, we're going to get into a little physics lecture here. I have a couple images on the next slides about the evolution of ultrasound. Of course, with anything, there are advancements over time, but the general production of an ultrasound image is used by high frequency sound waves. So what happens? Our machine will create the sound waves. It will send those sound waves into the patient's body by our camera, and the medical term for that is a transducer. And that sound wave, once it's in the body, it's going to travel through all of the tissues. And as it's traveling, it's going to start to bounce off some of those organs, some of those tissues, and travel back to the transducer. Once it's in the transducer, it will then communicate with the machine and our image will be produced. And all of this is happening essentially at the same exact time. So all of this moves so fast that we're able to have our image look like it's playing a movie, and there's no interruptions and there's no processing time. So our equipment has become extremely advanced, and the sound waves are very particular and precise, and they're very gentle, and there's a lot that goes into the production of the image, but this is essentially how we're using sound waves. They're created in the machine, they're sent into the body, they interact with the tissues, they get sent back to the machine. So it's very much a give and take relationship. When we're talking about high frequency, if you've taken a physics course, this term may sound very familiar to you, but we have an audible range of sound frequencies that we can hear as human beings, and anything over that audible range, that maximum audible range frequency, is where we're going to be operating in ultrasound. So anything traditionally over 20,000 hertz, hertz is the units that we use for the frequency of sound waves, that is something that we cannot hear as humans, but we are using it to process these images because of how they're behaving with the tissues. It's an interesting phenomenon, but if you've ever seen anything like this online, or if you go on YouTube, you can kind of test your frequency range of hearing. And the younger you are, the higher the frequency you can hear. As we age, that amount becomes less and less. So if you think about our grandparents who are older, right, they can't hear you. They can't hear certain things because at a certain age, the amount of our frequency range that we can hear decreases. So it kind of give you a little perspective on how that would work. Here we have the evolution of the equipment itself, and just very basically you can see those top images, super old. This is starting back in the 50s and 60s, kind of moving into the early 70s as well. Really, it didn't become used for healthcare until the 80s. So there was a lot of research that went into ultrasound to be used as a clinical piece of equipment prior to its inception. So a lot of research, a lot of time went into this. Patients were actually submerged in pools, and they were using the water in the pool to act as a conduit for the sound waves to travel from the machine into the patient's body. And now we've advanced to using gel. So we use gel. If you've ever had an ultrasound or seen someone have an ultrasound, they just squirt a lot of gel either on the camera or on the patient, and we use that to help our sound waves travel into the body from the transducer. So all this equipment has drastically advanced in really a short period of time. The 1980s might seem like it was a really long time ago for those of you who are listening, but in the grand scheme of medical advancements, it really isn't that long ago. And we've just seen a lot of drastic leaps in this profession, and it's really exciting. So you can see the equipment has certainly gotten better as we go. It's gotten more user-friendly, more ergonomically dynamic, more portable, and it's really benefited not only the operator, but also the patient. Now we have a new application of really kind of just handheld ultrasound, where you can plug a transducer into a specific phone that has a certain software on it, and you can have it in your pocket wherever you go. So we're seeing a lot of emergency room physicians using handheld ultrasound devices so that they can just check for quick internal bleeding or things of that nature. It's a little scary because really anybody can buy one of these, and not everybody knows what they're doing with it. Not everybody knows the anatomy, not everybody knows what to be looking for. So it's a little scary that the general public can just go and buy a portable ultrasound machine, but there's really not anything that they're going to be able to do or find with it unless they have the education. And here we have just the evolution of how our images have gotten better over that time frame. So again, images on the top, very old, and you can see that we've progressed into way more detail as we go down from the bottom pictures. We're still operating a lot of our standard exams with images of this nature, and this is called our 2D, so we're looking at things in 2 dimensions. There are certain reasons why we would add in a 3rd dimension and operate with 3D imaging right here, but it really slows down our system. So it gives a lot of great detail for a singular picture. It doesn't give a lot of great detail for overall imaging of an organ or a body part. So we're using it for very specific reasons. And a lot of times we are using it for OB or obstetrics, which is when we look at babies. Yes, we're doing it to look at their cute faces for the patient, but in reality, we're looking for cleft lip, cleft palate, we're looking for facial abnormalities, we're looking for abnormalities with the baby's neck, and the 3D application really gives us a better, well-rounded understanding of those small fetal structures. And then we can even add in a 4th dimension, which is adding in the concept of motion to kind of smooth out some of those details from the 3D. And again, we're using it for very specific reasons. Yes, it's cute. Yes, it gives our patients the option to see their baby, but we're doing it for a more medical reason. So what can we see with ultrasound besides babies, right? We've already said a lot of people, that's what you think that we do all day, every day. And that is so far from the truth. If you do not have an interest in scanning babies at all, that's fine, because you can be an ultrasound tech and never scan a baby exam or an obstetric exam. So we'll talk about that. The majority of our profession is scanning everything else, and that is what we call a general tech. So that is the majority of our profession, that's the majority of the jobs out there, and that is the majority of where we're going to see a lot of career advancement and further development. So if you want to scan babies, great. There's a lot that goes into that, which we're going to talk about. But if you have no interest in scanning babies at all, I still want you to consider this profession. So what else can we see? We can see any soft tissue organ, so anything in the abdomen, the pelvis, up in the neck. We're doing a little bit more with transcranial imaging, where we can look at some brain tissue. We also do breast ultrasounds, where if you have a mammogram done and they find something, they'll send you for a breast ultrasound to get better detail of what that something is. We also can evaluate blood vessels. Sometimes they can rupture, sometimes they can have clots, they can have blockages. Sometimes our toes and our fingers don't get enough blood supply, and we're looking at amputating a toe and a finger, but we can go in and see what's happening with that circulation to those areas. We can evaluate muscle tears. We're seeing that a lot again with those sports injuries and that musculoskeletal ultrasound. And we can also do a lot of interventional guidance. So we're going up to the OR, we're going into sterile procedures where we're helping the physician biopsy something, remove something, drain fluid, and really kind of just give them essentially immediate insight into what is happening in that patient's body while they're doing a procedure. So it's very, very well-rounded, and it's a lot of different options, a lot of different things that people can really explore in this profession. So here, I mean, even just looking at these images, this is a trauma, an example of a trauma patient coming in from some sort of terrible accident, and they're looking for internal bleeding. They're looking to find the source of that internal bleeding and how intense it is. We can see that right here on the screen. So soft tissue structures will appear a specific shade of gray, and fluid structures like regular body fluid or blood will appear black. So we can see that this patient has some internal bleeding or hemorrhaging going on, and they're trying to find the severity and the source. So speaking about obstetrics, I don't want to dismiss it at all. I just want to make sure that people understand that when you are scanning babies, that it is for a bigger reason and for a medical reason. A lot of OB, the majority of OB, is not sunshine and rainbows. It's very rare that we would be scanning a woman for an obstetric exam just routinely. It's something that if we're having to scan somebody outside of their normal appointments, it's because there's potentially something wrong. And that can be very hard, not only for the patient, but for the technologist, for you as the person scanning that woman and that patient. So it's not just for those cute face pictures. It's not just for the gender reveal. It really is to make sure that the baby is growing and developing properly. There are a lot of fetal conditions that the general public just don't know about. And sometimes, knowledge is scary, but we need to protect our patients from that. So we keep it fun, we keep it light. And in the back of our mind, we know that we're searching for something. We know that we have to make sure with 100% certainty that we are seeing what we need to see. We are measuring what we need to measure. We are looking for what we need to look for to ensure that that baby is developing properly and there are no complications that that patient needs to worry about and that that patient's team needs to worry about. We are using ultrasound to identify any fetal anomalies before birth. A lot of circumstances with fetal abnormalities or anomalies, they can either be fixed, and I say that with air quotations. They can be accounted for before the baby is born so that the delivery is not as traumatic, and so that they have planning in place if the baby does need surgery after birth. There are certain conditions where you can do surgery while the baby is still in utero, and that's that maternal fetal surgical guidance. We're using ultrasound to help a surgeon not only operate on a woman, but operate on a baby inside of a woman, using ultrasound, making sure that they are both safe and that they can go in and fix the problem or adjust the problem so that the baby has a better outcome at birth and after birth. So there's a lot. There's so much that goes into obstetrics. You have to know about all of those abnormalities. You have to know what you're looking for. And this is an example here. The image is showing how they're using ultrasound guidance during a maternal fetal surgery. So you can see that we have a lot of soft tissue going on here. This is a maternal soft tissue, and then this is the fetal tissue inside. So really just using ultrasound for precision and for immediate real-time imaging in these very high-risk procedures. This chart is an example of all of the structures that we have to look for when we're doing an obstetric exam. It's a lot, and it's not just looking for them and saying, oh yeah, I saw that, right? It's how do you document it? How do you measure it? What should it look like if it's normal? If it's not normal, what does it look like? What do you mean it's not normal? These are all of the things that we have to look for. So it's a lot, and it's time consuming, and it's stressful. And the whole time you still want to make sure that you're providing that high quality patient care while you are hyper focusing on performing this exam precisely. So it's a lot. Those of you who are interested in scanning babies, I just like there to be an understanding of what that truly means. And here we have just a progression really quickly. We're going to get into some fetal anomalies on our next slide, and then we'll get into some other non-OB related images following. But here we have what a pregnancy looks like as it develops at all of the different stages. A pregnancy is essentially 40 weeks. So everybody says you're pregnant for 9 months, but you're not, you're pregnant for 10. And there is a lot of changes that happen in those 40 weeks. And it may seem like it's a long time. It's almost a year, right? But there is so much that happens essentially from nothing. So you learn all about that process of the sperm meeting the egg and that fertilization, and where does that happen, and where does implantation occur, and what time does implantation occur, and when do these things start to change. So you have to know what the normal range of appearance is based off a timeline. And really looking at picture number 1 here, this is going to be one of the earliest signs of a pregnancy. We have our fluid-filled gestational sac. We have a supporting really primitive structure here, the yolk sac. And this tiny little glob right here is the very first signs of an embryo. And then within a few short weeks, so this is about 5 weeks gestation, by about 7 or 8 weeks, this is what we're looking at. So look how much this tiny little blob grew in really 3 weeks. It's crazy. Everything develops so rapidly. So here we're about 7, 8, 9 weeks, give or take a ballpark. This down here is probably about 18 to 20 weeks. So again, a lot of rapid development. And this is last trimester. This is 36 to 40 weeks, right? Fully formed, ready to go. Look how big those hands are, right? In comparison to, boop, this tiny little hand up here. So a lot happens in a very short time frame, and you have to be aware of all of those changes in relationship to the timeline. Here we have some fetal anomalies. These are really what we're looking for, right? This is the important part. Picture on the left-hand side, you can pause me for a moment if you want to try to see what's wrong with these images, but if not, I'm just going to keep talking. Picture on the left-hand side is an image of a baby's hand. Things that are very, very dense, things that are bony in nature are going to appear white. So if we count, the baby has 1, 2, 3, 4, 5, 6 fingers. That's an abnormality, right? Why does the baby have 6 fingers? Okay, now we got to do a little bit of healthcare research here. The team's got to figure that out. Why does that baby have 6 fingers? Is it a random occurrence? Is there a genetic problem we need to be aware of? What else is going on with that baby? Pictures in the middle, these two are in relationship to each other. So image on the top here, this is a normal profile picture of the baby, and we're looking at the belly. So there's typically earlier in the pregnancy, in the 2nd trimester, we tend to see what is called a midgut herniation, and that's normal. It's this little lump right here in the baby's anterior belly, and it's just accounting for the rapid growth. So very normal, not anything to worry about. Different baby here, same view, profile view of the baby's face and abdomen. We can see that that midgut herniation does not look normal, and all of this bowel is coming out. So that's a problem, right? They don't want to have that baby born going through the birth canal or going through a C-section with their bowel hanging out of their belly. So this is a condition called gastroschisis, and a lot of times they will try to go in and do one of those maternal fetal surgeries where they can push the bowel back in and hopefully repair that baby's abdominal wall. So it's all important in terms of every detail that we're looking for. Picture on the right hand side, this is a 3D image. This is one of the reasons why we would be doing a 3D image. We're looking at the baby's neck. We can see that the umbilical cord is wrapped around it. So of course, that's a big concern for birth. We want to plan accordingly for that because the baby could essentially suffocate themselves and be born not breathing and resulting in a stillbirth. So very important reasons why we would be doing exams and not just for the cute, fun part of it. So what else can we do? We said that we've done a lot of soft tissue organs, so anything in the abdomen, pelvis, neck. We can also look at lymph nodes. We can look at anything that is vascular in nature, so arteries, veins, any kind of cardiovascular condition. We can look at tumors really anywhere in the body and be able to determine if they are benign, which means not concerning, if they're malignant, which means cancerous, if they're reactive, meaning that they're responding to a recent illness that the patient has had, or if they're metastatic, meaning that the malignant cancer has now spread elsewhere into the body. All of those different types of tumors will look different on ultrasound, and we learn about that through the program. Fluid collections we can look at, so if a patient has a muscle tear, that can sometimes result in a lot of fluid collections. We can look at anyone who has been through a trauma. We can see if they're bleeding internally, where that bleeding is coming from. If the patient has an infected abscess, so they've had an infection that has progressed without treatment or without responding to treatment and has now formed into an abscess. And also we can look for any fluid collections that are in response to diseases. So while we're speaking about that, there is a condition called ascites. And ascites, if you do a quick Google search, it is when our body just accumulates a lot of extra peritoneal fluid, meaning we get a lot of extra fluid that gets trapped in our abdomen. There are a lot of reasons why somebody can develop ascites, and one of those main reasons is liver disease. If our patient has cirrhosis, if our patient has liver failure or fatty liver disease, it results in ascites. That is this picture that we see in the background of this slide. This is not a pregnant patient. This is a patient whose belly is so full of ascites that they look pregnant. So we can actually go in there and drain that fluid. It's one of the most interesting procedures to see because our patients come in with these big pot bellies. They look like Santa Claus. They look pregnant. And we find their fluid pockets in their abdomen. The screen is showing that right here. All of this is fluid that needs to be drained. We go and drain all of that fluid out of their abdomen, and then they leave with a six-pack. It's very, very interesting to see. They have a lot of immediate relief. It's more of a therapeutic process, but we can really look at fluid collections everywhere and kind of figure out what the reason is for that patient having a fluid collection. We also can look at functional processes. So we just said the liver can be diseased and cause ascites and cause a fluid collection in that patient. But we can also look at other organs that are starting to fail. We can look at transplants, make sure that they're not being rejected by the patient's body. We can look at acute and chronic diseases, meaning that this is something either new or something that they've had for a while. Or we can look at systemic diseases. So we see a lot of patients will come in with a thyroid disease, and it has a whole effect on their body. Their lymph nodes can look weird elsewhere in the body. Their adrenal glands can look weird elsewhere in the body, really depending on what's going on with that patient. So not only are we taking the images, right? We need to know how to take the images and what these things look like. We also need to be able to piece the puzzle together for the healthcare team. And that's where that creative thinking comes in. We have to be well-rounded in healthcare knowledge, as well as the expert in our ultrasound field. So there's a lot. Here are some examples of soft tissue. So these are both examples of a liver. On the left-hand side, this is a normal, healthy liver. We can see this gray shape here, right, with this white outline. This is all liver tissue. And then this picture over here, this is the outline of the liver, but there are clearly things going on in here, right? All these black things in the normal liver, these are all the normal blood vessels to that organ. These are not. This is metastatic cancer to the liver. All of these tumors are all metastatic cancer that is spread from elsewhere in the body to the liver. We also can see that because this organ is undergoing some sort of disease, we have a fluid collection starting. We have some ascites starting. We can see this black fluid here. This is not black fluid. This is soft tissue around the normal liver. So just kind of give a little perspective here of normal versus abnormal. Here we have two pictures of a of a non-pregnant uterus. Picture on the right-hand side is considered normal. Everything kind of looks like a kidney bean, right? It's this kind of vague outline here. And then we have the internal lining here, our endometrial cavity, for those of you who like anatomy. This is all normal, nothing crazy going on here. This picture, same thing, outline of the uterus. This one's a little bit closer up than the one on the right-hand side, but that endometrial cavity is now all filled with fluid and has these tumors. So all of these are tumors that are producing this excess fluid in the endometrial cavity that should not be there. So again, normal versus abnormal. On the left-hand side here, we have a nice picture showing, again, some liver tissue and our kidney right next to it. If you didn't know, your kidney is one of your kidneys, your right kidney, is very, very close to your liver. They essentially hug each other. So this is all normal, showing that nice border between the liver and the kidney. Pictures on the right-hand side, this is what happens when somebody has a lot of excess fluid or ascites in their abdomen. It doesn't have anywhere to go, so it starts to push these organs away from each other, right? So this is the liver, this is the kidney, and this is all the fluid that really doesn't have anywhere to go except in between those two organs. And then down here, again, showing that ascites fluid, these are all loops of bowel. So when you're doing those drainage procedures, you want to make sure that you don't stick the needle into the bowel. You want to make sure that you stick it into the fluid to drain out the fluid. Moving in, oops, sorry, I jumped ahead a little bit on my recording slides. Moving into some non-soft tissue organ images here. Here we have an example of a vascular study. So we're looking at arteries and veins here. We do a lot of vein studies of the leg because people can get blood clots, or if you've heard of a DVT before, a deep vein thrombosis. That's what we look for. So our arteries and our veins, they typically run together in the body. They're paired. Artery goes away from the heart, vein goes towards the heart. So when we're looking for a deep vein thrombosis, we know that we're going to see our artery nearby, but we're really looking at the veins to see if there's any blockage. So veins should appear nice and black because they are fluid-filled structures. Normal picture on the left-hand side here. Picture on the right-hand side, all of this junk is trapped inside that vein. So that's going to indicate a blood clot. So we would want to make sure that we treat that appropriately. Showing a really cool Achilles MSK study. So our Achilles tendon, some of you might have just gotten goosebumps in your hair, might have stuck up on your arms, because your Achilles tendon is just one of those like very, very sensitive structures for some reason. When we're looking at the normal Achilles tendon, it looks like a box of spaghetti. And that's going to be this picture over here. So everything is very linear. You can see all of the muscle fibers in there. Perfect. All of the tendon fibers in there. Looks like a box of spaghetti. When we have a disruption in the Achilles tendon, it snaps and recoils. So it still looks like a box of spaghetti over here, but now we have this big kind of coiled bulge. We have a disruption and we have a fluid collection. So this is a torn Achilles tendon. So we're seeing a lot more of this with some of our athletes. We see a lot of high school basketball players. We see a lot of football players coming in for things like this. So it's definitely the newer aspect and application of ultrasound. Moving into breast here, we said that we can do a lot of follow-ups from mammograms. This was kind of my wheelhouse before I got into education. I was a breast technologist. I was a general and a breast technologist. I was also doing a lot of vascular exams as well. So I was finding a lot of breast cancers in these follow-up patients. Normal breast tissue is on the left-hand side. There are a lot of different layers to breast tissue. It all kind of looks like ocean waves, and that's normal. Anytime we see something that looks like a rock in there, we're going to be concerned for a mass. Picture on the right-hand side, this is a very clear-cut breast cancer. It's very, very dark, but it's not black. It's pointy, right? So if we look here, we have a little point, 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 point. Cancer likes to spread. It likes to invade. It's like this aggressive army, and that's what it does with the points. Anything that's nice and smooth, anything that's nice and round, we don't worry about as much, but once it starts to get pointy and sharp and very, very dark like this, we get a lot more concerned. Those are also harder moments as the healthcare professional. A lot of breast centers will essentially give the patient that news when they come back for that follow-up imaging. So they're leaving there with answers. They're leaving there knowing that they most likely have cancer and they need to schedule some procedures. And you're the last one to talk to them. So the physician will come in, will give them the news, and then they leave the room and you're with them. And it's hard. And a lot of patients can either get angry or devastated or just immediately start crying, and you want to make sure that you are providing them what they need from you in that moment. If your patient is sitting there crying, having just received this news, the human thing to do is to comfort them. You have to learn a lot about people to work in this profession. There are some patients who come in and they are angry and they just want somebody to hear their anger, and they're not angry at you, they're not angry at the place where you work, they're not angry at the doctor, they're just angry because their whole life has been turned upside down, and all you have to do is listen. Other patients, you can just feel that they need a hug, right? So you kind of learn what your patients need from you, and it takes a lot of time and a lot of experience, but that's a very important part of this job as well, is the human aspect to this, being able to relate to somebody in an empathetic level, even though you may never be able to relate to them, right? We see a lot of sadness, and we need to be able to handle that and provide to that patient what they need. Moving into surgical guidance here, so most of the time when we're doing ultrasound guided procedures, the patient is awake And again, you're kind of getting back into that empathy where your role, yes, is to be the professional technologist for the healthcare team and make sure you're doing your job properly, but also balancing what that patient is going through. So we do a lot of biopsies of breast masses, liver, kidney, thyroid, soft tissue masses. And in those situations, those patients are kind of in limbo, right? They're getting a biopsy because we saw something bad, right? We saw something that we're really questioning and we need confirmation. So the patient's already been given that sad news and they're kind of just waiting of, do I actually have cancer or is this thing gonna not be cancer? And they're still nervous, they're still anxious, and now they've been waiting, right? So they got that news however many weeks or months ago. They had to wait to schedule their biopsy, and now they're back. And now they might be even more angry, and now they might be even more worked up. Some of them might be calmer because they've had time to process, but some of them are not. And while you're still being that right-hand person for the physician doing the biopsy, you still need to check in with that patient. You might need to hold their hand with one hand and hold the transducer with another hand. And it's all about being able to provide that for the patient at the same time as providing high quality assistance for the person performing the procedure. We also do procedures that are known as cryoablations, where we can actually go in and freeze tumors. It's a really cool and up-and-coming application using ultrasound guidance. We learned previously that we can use ultrasound guidance for those maternal fetal surgeries. Some women have to have their uterus essentially scraped, for lack of a better word, but that literally is the word for it, whether it be from a miscarriage that their body can't naturally pass, or from those masses that we saw in that endometrial cavity. They have to go in and have all of that removed, and we use ultrasound to help guide that as well. Organ transplants, like we mentioned early on, we want to make sure that those organs are not being rejected, so we're using ultrasound to confirm the vascularity to those organs, and then the injections and drainages like we talked about with the ascites and things of that nature. So very, very neat interventional things that we're doing more and more of in the general ultrasound world. Emergent ultrasound. So this is something that is it's a controversial thing in the professional world because there are some conditions outside of this list. I'm just laughing because I just can place a lot of my stories to this. But there are a lot of conditions outside of this list where emergency room providers believe that it's highly emergent, right? I'm ordering if you ever heard stat, right? That means you need to do it essentially as soon as you possibly can. A stat thyroid. It just isn't, it's not a crucial organ. It's not a crucial exam. So we kind of just see a little bit of ordering abuse with emergent ultrasound. Now there are certain indications and reasons why we would need to do an ultrasound essentially immediately. And that is going to be this list here. And even some of these are a little bit questionable. There are things that the physician can do clinically. So there are a lot of jobs where you will get called in the middle of the night. If you're on call at a hospital, you will get called in for rule out cholecystitis. And it's not really something that you need to be called in for at 3 o'clock in the morning. It can wait until 7 when the next person gets there, but that's just part of the profession. Things that cannot wait: torsions, ectopics, and appendicitis. Those cannot wait, especially torsions and ectopics. What a torsion is, we see this with testicles in men, and we see this in ovaries in women. These organs are kind of free floating in the body. They don't have a lot of supporting structure. And what happens with free floating organs is that they can kind of go out and do whatever they want. They can move around, they can swirl, they can twist. So when the testicle or the ovary twists on itself, it cuts off its own blood supply. And if you don't adjust that blood supply and that twisting, that whole organ can die within 4 hours. So that is very much an emergent situation, right? We need to keep people's organs. The other emergent situation is going to be an ectopic pregnancy. An ectopic pregnancy is when a pregnancy develops anywhere outside of the endometrial cavity. So it can develop in the ovary, it can develop in the fallopian tube, it can develop in the cervix, it can develop anywhere. It's highly concerning for that woman because if it is not growing in the endometrial cavity, it's growing in a space that cannot accommodate a growing pregnancy. The only space that can accommodate a growing pregnancy is in the endometrial cavity. Everything else cannot support it. Everything else is too weak. If that pregnancy grows where it shouldn't be, it will rupture, and the mother has a very high likelihood of internal bleeding and death. So those things we need to find immediately and get those patients to surgery. Now, both of these examples, torsions and ectopics I just spoke about, these are going to be our images on the top. So on the left-hand side, this is a side-by-side picture of two testicles. The testicle on the left side is showing red and blue. That's showing blood supply, blood flow. The testicle on the right-hand side is really, really big, and there's no red and blue in it. That means it's not getting any blood supply. That means that is the testicle that has torsed. So they need to go in and fix that. The picture on the right-hand side showing the ectopic pregnancy, you can see on there that on the left-hand side, it says UT, that stands for uterus. And on the right-hand side of the ectopic, it says LOV, and that stands for left ovary. So this ectopic is growing in the fallopian tube between the uterus and the left ovary. So that's very, very, very concerning. And you can see that fluid-filled gestational sac with the embryo already developing. So we really need to prioritize that and get those done immediately. As for appendicitis, we can see it right here. It's this inflamed appendix. There are things that the physician can do. They can put the patient on antibiotics. They can give the patient a CAT scan to confirm appendicitis as well. So there are other options for that condition that can be adjusted for on an emergency basis. Same thing with the DVT. So that's that blood clot in the vein. If the physician is suspecting a blood clot, they can proactively put the patient on a blood thinner until there's confirmation of that. So again, things that the providers can do without having to rely solely on ultrasound. And cholecystitis, this is inflammation and infection of the gallbladder. That's going to be this picture on the bottom here, where the gallbladder is very sensitive to infections and diseases, and if it does progress, it can rupture, but it takes a very long time for cholecystitis to rupture. There are, again, other imaging options that the providing team can do. They can order a CAT scan, they can order blood work to be able to rule that out. So these are really going to be the reasons why a provider would need an ultrasound immediately to rule these things out and to hopefully get a patient to surgery sooner rather than later. So talking a little bit about the job in terms of, is this for you? What questions may I have about this? And what can I get out of this lecture? There is a professional responsibility. I'm pretty sure I've made that abundantly clear. But if that's not something that's for you, then that's a choice that you have to make. There is a lot of direct patient contact. Everything that we're doing is involving touching the patient. You're able to form really positive patient relationships. So some of these conditions, depending on where you work, some of these patients will come in pretty frequently, and you kind of get to see them and get to know them over time. Most responsibility is going to be in how we conduct our cases that are not routine. So how do we report critical findings? How do we report and handle a fetal demise, meaning a baby doesn't have a heartbeat? How are we able to provide support during those procedures or those really emotional exams? And how are we able to communicate all of that to our doctors? Again, if we do not see something, if we do not document something, the doctor doesn't find it, the doctor doesn't see it, there's no diagnosis, or there's delayed diagnosis. And we don't want that. We don't want that for our patients. We wouldn't want that for ourselves. We wouldn't want that for our loved ones. So we are really writing preliminary reports for our radiologist. We're showing them what we saw, we're communicating what we saw, and that's all they have to go off. They're not able to make up a diagnosis if we didn't show them something. So it's really a lot, and it's very stressful. I put this chart here with this link in this Futurama picture because I tend to be a little bit sarcastic sometimes. And in 2019, there was an article that was posted just by a regular journalist saying that the least stressful job was a sonographer, an ultrasound tech. And I laughed and laughed and laughed when I saw this. And then I took a moment and I looked at the rest of the list, and I also saw that an audiologist, who's a physician, doesn't have a stressful job. Also, an operations research analyst doesn't have a stressful job. A pharmacy tech doesn't have a stressful job. It was wild to me. And all I know is that whenever I go to my hairstylist, there is always somebody who is angry and disgruntled in there for some reason or another. So, I mean, that's pretty stressful to me as well. So it's just really funny. Like, people just have a very different understanding of what this profession actually is. This is the person who thinks that we are just scanning babies all day long because it's fun and cute. They just really don't know. And I like to think that if I make my job look easy, then that means I'm really good at it. So you kind of take these things with a grain of salt. So how much money do you plan on making, right? Because at the end of the day, nobody works for free. Nobody's going to go through a very hard academic program for, a job that doesn't pay well. And it really all depends. You need to always be bettering yourself. You need to have the skill necessary for an employer to pay you more. So it all depends on really a range of factors. What type of registries have you passed? There are a lot of different registries in ultrasound. What have you done? What have you passed? What are you good at? What is the type of clinical setting that this job is looking like? Is it a hospital? Is it an outpatient center? Where are you going to be working? How many years of experience do you have? What type of experience do you have? What's your educational background? Did you go to an accredited program? Did you not go to an accredited program? What does that mean? The cost of living rates in the area where you're looking, right? And cost of living rates are high everywhere right now. So it's something that you just need to consider. Also, do you offer anything extra? Do you offer this employer anything else that could be useful for them in order to pay you more? Additional languages? Are you a phlebotomist? Do you have a history of being a CNA or a medical assistant where you can help provide extra services to the department? All of that really matters in terms of getting a job and what that job is going to pay you. So ultimately, you need to make yourself more marketable. Multimodality, multi-registered, meaning multimodality. If you want to go back to school for X-ray, do it. If you want to go back to school for MRI, do it. Be multimodality. Multi-registered is meaning how many registries do you have within that modality? What is your experience in different clinical settings? If you're in a hospital, you've been to the ER, you've been to the OR, you've been up to the ICU. If you have outpatient experience, what type of outpatient experience? If you've been a travel tech, have you done national placements or international placements? If you've worked in comprehensive care centers, that means you're going to nursing homes and senior centers and care facilities. And what does that all mean? All of that plays into your experience. So personally for me, this is what I call my alphabet soup. So my name is Emma Bob. I have a master's degree. I'm a registered radiologic technologist. So I also have X-ray. I am a registered diagnostic medical sonographer, RDMS, meaning I passed my physics registry, which we'll talk about, and then I passed my abdomen specialty, my OBGYN specialty, my breast specialty, and I am also a registered vascular technologist. So I passed my vascular technology registry as well. So, and I'm not even done. There is still more that I can do and that I'm prepping to do as well. So it's really about making yourself marketable, bringing more to the table, not only for yourself, but for your patients, right? And ultimately that is going to result in you getting the jobs that you want, the career advancement that you want, the pay that you want. You have to put in that work for you, and you will then see the benefits be reaped after. So let's take a look at kind of general pay. So this was from 2020, and I have looked up results from 2024, and these essentially have stayed the same. So I liked this graphic better. I kept this graphic. So even within the last however many years, these numbers have not changed. If anything, they've gotten higher. So salary outlook. This is, I should say, this is not for entry level. Okay, this is not for somebody coming right out of school. This is somebody with 3-ish years experience. And 3 years goes very quickly. So right now, Rhode Island is in the top 5 of highest paying states for ultrasound, which is crazy, right? There is such a demand, and that demand is not going anywhere. If you were to go on Indeed and look at job opportunities right now for ultrasound, there is a lot in the state. Pay, I mean, $92,000. That's a lot. That's a lot of money for right now. And I know everything has gotten more expensive, but think about that. Going to a program like this for 20 months, right, or however long it may be, it's really worth it, right? And even though these numbers are not for a new graduate or somebody brand new with no experience, somebody brand new with no experience in this area, you know, my students, they report back to me $37 an hour. It's pretty good. And that doesn't account for if they work a night shift, if they work a weekend shift, if they work overtime, if they take call. Their base pay is $37 an hour for brand new, right out of school, no experience. It's pretty good, knowing that that number is only going to drastically increase, especially if you make yourself more marketable. So making yourself more marketable, right? You got to pass these registries. So what does that mean? X-ray, MRI, all the other modalities, they take one registry and they're done. That's not the case for us. So with ultrasound, you have to take and pass a physics registry. So sonographic principles and instrumentation. That is built into the program. So the program does require students to at least attempt that registry while they are still students. And that kind of essentially gets one registry out of the way. By the time you're ready to graduate, you're ready to take your specialty exam or your specialty registry, which would be abdomen or OBGYN from this program. Once you have one of those, so once you've taken and passed physics and then taken and passed a specialty, then you are fully registered. You are ready to work. You have your RDMS credentials. There are other exams that you can take, like vascular, breast, pediatrics, musculoskeletal, and I really always encourage students to continue to take those exams. There's a lot that goes into preparing for a registry, but it does come with time and effort, and it is worth it. So here are some pictures of my students who took their registries together, which was a little risky in my opinion. If it were me, I don't know if I'd want to take my registries with my friends, because what if I'm the only one who comes out and doesn't pass it? But all of these students are really fantastic. They're really well prepared. The program really prepares students to take and pass on the first try. And it's something that I am very, very proud of, and it's something that we've built really well. So there really isn't a lot of fear of not passing the registries, especially the physics registry, because it is so well focused during the exam, during the program rather. So if you are interested in this, what can you do? What could be some of your next steps? You can ask a facility near where you live if you can shadow and ask one of their technologists some questions just to see if you really like it. Do your research. There's no harm in Google searches. ChatGPT can answer a lot of questions. Apply for a nationally accredited program. Going to an accredited program really does matter. We put a lot of time, effort, and focus on you as the individual, making sure that your skills clinically and academically are where they should be in order to be successful, whereas non-accredited programs, it's not as individual based. It's not as well received in terms of the student really getting what they need on the hands-on. You will learn, if you are in a nationally accredited program, you will learn in a didactic and a clinical setting, meaning you will have classes and clinical work. You will successfully complete that accredited program, and then you will pass your registries. So it's a very straightforward process. There's a lot of work that goes into it on the student end. It's a very big time commitment, and you will hear about that. But you know, ultimately, it's really great and rewarding. Here are some pictures of some events that my students have done and some things that we do in the program. I have some pictures on the next slide of that as well. But we play a lot of games. We do a lot of Jeopardy. We do a lot of community service events where we're out in the community showing what ultrasound is. We really prioritize mental health and being able to provide high quality empathetic patient care, and a lot of that comes down to caring for yourself. So we do some yoga and meditation in some of our classes, and we have a lab component as well where you are working with the instructors one-on-one. They are physically holding your hand, you are scanning your peers, you're learning on your peers, so that when you are in the clinical setting you have some background knowledge and you're able to practice your skill a little bit more. And lastly, why Brown University Health School of Medical Imaging? Why this program, right? Well, you wouldn't be here listening to this if you weren't interested, right? If you didn't have a little background knowledge on what this is, but we are accredited. We're an accredited program by the JRC and by the KHEP. You could do a quick Google search on what that is, but it just means that we have really high standards. We have, the education that we're providing to students is really comprehensive. We spend a lot of time with the didactics, making sure that your academic knowledge is really high quality. We're also giving one-on-one hands-on guidance for the clinical component of it, learning how to physically scan. There's the textbook component and then there's the application component. Can you recall all of this information? Can you absorb all of this information? And then can you apply it with your hands-on skill? So we're making sure that there's a very good balance with that. We are doing frequent individual check-ins, making sure that you're good, you're progressing well, that your skill is where it should be, and that your academic grades are not of a concern. We also provide really great clinical experiences. So our clinical instructors are really, really involved in the students with our school, which is great. We also provide hospital settings and outpatient settings. Hospital settings, we're giving you exposure to ER, inpatient, pediatrics, the NICU, right, neonatal intensive care unit, maternal fetal medicine rotation, labor and delivery. We let you guys participate in a lot of those surgical procedures, so it's very, very involved. As for our outpatient facilities, we're seeing a lot of special procedures there. We're seeing a lot of MSK, that musculoskeletal procedure. We're seeing a lot of vascular evaluation, so a lot of those blood clots you're able to participate in. And as for our program, we have a greater than 96% job placement rate. And that's just because it would be 100, but I have had in the last 3 years, I've had some students relocate out of the area, and I just haven't been provided with their updated job placement information. So this essentially is 100% job placement rate. And then registry pass rate is greater than 95%. So within the last 3 years, out of all of my students, I believe there have only been one student who has not successfully passed on the first try. So that is where that comes from. So again, some pictures here just kind of showing my students out doing some work. We do a lot of community service events like we had mentioned here. We do a lot of professional preparation, so public speaking and presentations and really being able to convey complex topics. This is an example of a placenta and the placental supply to the baby. So really, really neat projects that the students complete. And then we do a lot of community service in terms of donations. So we work with Hasbro a lot, we work with local animal shelters, and we're really giving back to our community. It's a very rewarding profession, but it's also very rewarding to be a student in this program. I hope I was able to provide a lot of insight into this profession. If you have any questions about anything that we talked about today, please feel free to reach out to me. Maybe I changed some of your minds. Maybe I convinced some of you. But if not, always happy to chat, always happy to answer more, and I appreciate your time.